Hi, my name is Jamie Morgan, and I am a maternal-fetal medicine physician at University of Texas Southwestern. Today, I'll be talking about obstetric hemorrhage in the context of the Texas AIM Hemorrhage Bundle implementation. Since the pregnancy mortality surveillance system was put into place by the Centers for Disease Control and Prevention in 1986, the number of reported pregnancy-related deaths in the United States has steadily increased from 7.2 deaths per 100,000 live births in 1987 to a high of 18 deaths per 100,000 live births in 2014. This graph shows the trend in pregnancy-related mortality ratios, defined as the number of pregnancy-related deaths per 100,000 live births in the United States between 1987 and 2014, the latest available year of data. Here we can see the most common causes of pregnancy-related mortality in the United States, with cardiovascular disease and other non-cardiovascular medical issues leading the way, followed by sepsis and hemorrhage. Although obstetric hemorrhage ranks fourth in terms of its contribution to maternal mortality nationally, it is by far the most common cause of severe maternal morbidity. Importantly, much of the increase that we have seen in maternal mortality may indeed be preventable. The Centers for Disease Control and Prevention estimates that up to 60% of all pregnancy-related deaths are likely at least somewhat preventable. You can see here that hemorrhage and preeclampsia are consistently at the top of the preventability list, with up to 90% of hemorrhage-related deaths deemed at least somewhat preventable. That makes both hemorrhage and preeclampsia prime targets for quality improvement initiatives and prevention efforts. The concept of normal or average amount of postpartum blood loss was established by Dr. Jack Pritchard in 1963, when he studied 150 women at the time of delivery using chromium-labeled red blood cells. In 75 women who underwent vaginal delivery, mean red cell loss from the circulation was equivalent to 505 mLs. In 40 women undergoing repeat cesarean delivery prior to labor, the average blood loss equaled 930 mLs. And in 35 other women subjected to cesarean section plus total hysterectomy, the average blood loss was 1435 mLs. These average values have formed the basis of what many practicing OBGYNs define as normal blood loss for many, many years. Although this work delineated the average blood loss based on route of delivery, there is no universally accepted definition of postpartum hemorrhage. While it has been classically defined by quantities exceeding the averages Dr. Pritchard delineated, clinical estimates are notoriously inaccurate, and blood loss is often underappreciated. In 2014, the American College of Obstetricians and Gynecologists sought to standardize obstetric-related terminology for quality improvement and consistency purposes. This document defines postpartum hemorrhage more globally as cumulative blood loss greater than or equal to 1,000 mLs, regardless of route of delivery, or signs or symptoms of hypovolemia within 24 hours after the birth process. However, despite this new characterization, it should be recognized that a blood loss exceeding 500 mLs in a vaginal delivery is nonetheless abnormal and should prompt the provider to investigate potential causes for increased blood loss. At term, close to 600 mLs per minute of blood flows through the intervillous space. The spiral arterioles, which supply the space, have no muscular layer due to their endotrophoblastic remodeling, which creates a low-pressure system that promotes placental blood flow. Because of this high volume of blood flow to the uterus during pregnancy, there are physiologic mechanisms in place to prevent excessive blood loss at the time of delivery. Most importantly, there is vigorous myometrial contraction to compress blood vessels within the placental bed following placental separation. This compression is followed by clotting and blood vessel lumen obliteration. Importantly, however, the initial process of myometrial contraction does not require an intact coagulation cascade, and the functionality of the clotting cascade only becomes important if obstetric lacerations are present. In addition to these vital hemostatic mechanisms, pregnant women increase their blood volume, on average by about half, which equates to an additional 1,500 to 2,000 mLs for the average size woman. Therefore, the woman's body is prepared to lose the average 500 to 1,000 mLs that usually occurs at delivery. If blood loss is not excessive, as is true in most cases, the hematocrit will change very little postpartum. There are a myriad of clinical circumstances for which the risk of obstetrical hemorrhage and its associated complications are appreciably increased. However, the four most common are atony, retained products, obstetric lacerations, and coagulation defects. Of these, atony is by far the most common, accounting for 70 to 80% of postpartum hemorrhage. The clinical significance of this finding still remains somewhat uncertain, given that the majority of women, even in the high-risk group, did not require peripartum blood transfusions. Nonetheless, these findings are now driving quality improvement efforts to better recognize women at high risk for postpartum hemorrhage and prepare accordingly. Since atony is the most common cause of obstetric hemorrhage and is one of the most common postpartum complications we manage as obstetricians, it is important to review the medical management options. Oxytocin is routinely given in most L&D units to prophylactically prevent uterine atony and is not shown here. The two first-line agents for hemorrhage management are Methergin, a synthetic ergot derivative, and Hemabate, a synthetic prostaglandin F2 alpha analog, both which are given via intramuscular injection. Methergin stimulates tetanic contractions and lasts for approximately 45 minutes. It can be redosed every 2 hours for up to 5 doses. Side effects include nausea, vomiting, headaches, and severe hypertension. Hemabate can be given every 15 minutes for up to 8 doses and causes side effects in approximately 20% of women, including diarrhea, hypertension, vomiting, fever, flushing, and tachycardia. Another pharmacologic effect is pulmonary airway and vascular constriction. Thus, Hemabate should not be used for asthmatics and those with suspected amniotic fluid embolism. Misoprostol is a synthetic E1 analog that is typically administered either orally, sublingually, or rectally for prevention or treatment of uterine atony. And finally, dinoprostone or prostaglandin F2 can be used off-label and is given in a 20 milligram suppository per rectum. Misoprostol is considered by many to be a second-line agent due to its pharmacokinetic properties. The time to peak concentration varies somewhat according to route of administration, but is somewhere in the neighborhood of 30 to 60 minutes. Specifically, this study of rectal administration demonstrated a time of 41 minutes to peak concentration. Importantly, time to achieve uterine contractility is even further delayed, with about 100 minutes being reported in the literature. Because rectal administration of misoprostol takes about 60 minutes to reach peak circulating concentrations, and time to onset of uterine contractility is over 1.5 hours, many have advocated that it not be used as a first-line uterotonic. Rather, parenteral uterotonics, such as Methergin and Hemabate, should be prioritized in the management of postpartum hemorrhage. In order to make these first-line medications easily accessible and readily available at Clements University Hospital, we have developed an L&D medication kit that will be brought to every delivery by either the bedside or charge nurse. It contains a single dose of Methergin and a single dose of Hemabate. These medications will remain in the room with the patient until she is stable and ready for transfer to the postpartum floor, at which time the medications will be returned to the Pyxis. If bleeding persists after initial measures for atony have been initiated, the following management steps should be implemented immediately and almost simultaneously. The provider should provide firm bimanual compression with both hands and request help immediately, including additional nursing support, OB or MFM assistance, and anesthesia help. Blood products should be requested, 2 large bore IVs secured, and a Foley should be placed. Volume resuscitation should begin with rapid infusion of crystalloids. With adequate anesthesia, additional causes of obstetric hemorrhage should be explored, including retained fragments and cervical lacerations. If bleeding continues or the patient is hemodynamically unstable, blood should be given and preparation made to move to the operating room for additional management. If heavy bleeding continues despite uterotonic administration, tamponade techniques can be explored, including Foley balloon placement or placement of a Bacri balloon. In prospective studies, nearly 150 women were managed for postpartum hemorrhage using uterine balloons. Perhaps a fourth were caused by uterine atony. For all cases, the success rate was noted to be approximately 85%. Combinations of balloon tamponade and uterine compression sutures have also been described. Manual compression of the uterine vessels using suture techniques is also an available option for intractable atony. Although no large randomized trials compare compression suture techniques, the B-Lynch technique has been used for almost 20 years. The B-Lynch technique uses delayed absorbable suture to compress the anterior and posterior uterine walls and compress bleeding vessels. It is easy to perform and appears to be safe and is often effective, with a success rate of 75 to 80% reported in the literature. A transverse suture technique can also be used to control postpartum hemorrhage. For this, interrupted sutures of number 1 chromic are placed along the anterior uterus at 3 to 4 centimeter intervals. Once they are tied down, they provide uterine compression and juxtaposition of the anterior and posterior uterine walls. In 1986, O'Leary first described bilateral uterine artery ligation for post-cesarean delivery hemorrhage. Uterine atony was the major indication for vessel ligation. He described this technique as potentially helpful in 95% of cases. Although others have not noted it to be effective in the case of atony, it is a potential adjunctive technique that can be employed in cases of persistent hemorrhage. There are many other causes of obstetric hemorrhage that have not been covered here. However, these are considerably less common. Nonetheless, they have the potential to lead to serious obstetric morbidity. In obstetric, coagulopathies can develop and often lead to significant morbidity or even mortality. And although often indistinguishable clinically, there are pathophysiologic differences between the types of coagulopathy seen in obstetric patients. Dilutional coagulopathy results from massive loss of procoagulants due to excessive hemorrhage. In contrast, a consumptive coagulopathy occurs when there is actual consumption of procoagulants within the intravascular tree. Although the various syndromes shown in the graph all cause some small degree of consumptive coagulopathy, the two syndromes that are most highly associated with significant disseminated intravascular coagulation are abruption and amniotic fluid embolism, which is not shown here due to its rarity. This is the acute hemorrhage classification scheme used by the American College of Surgeons. While this isn't 100% applicable to obstetrics due to some of the pregnancy-related physiological changes that occur, these values can be generally applied to any bleeding patient. When the blood volume deficit exceeds 25%, compensatory mechanisms are typically inadequate to maintain cardiac output and blood pressure despite significant shunting of blood centrally. Following an initial increased total oxygen extraction by maternal tissue, maldistribution of blood flow results in local tissue hypoxia and metabolic acidosis. This creates a vicious cycle of vasoconstriction, organ ischemia, and cellular death. During an obstetric hemorrhage, urine output is one of the most important vital signs with which to monitor a woman. Renal blood flow is especially sensitive to changes in blood volume. Unless diuretic agents are given, and these are seldom indicated with the actively bleeding patient, urine flow should remain at least 30 mLs and preferably 60 mLs per hour. In cases of postpartum hemorrhage, initial resuscitation efforts focus on rapid fluid replacement. However, this fluid rapidly equilibrates in the extravascular space, and only 20% of crystalloid remains intravascularly in critically ill patients after 1 hour. In general, ongoing hemorrhage requires resuscitation with blood in addition to crystalloid. This should be considered when blood loss is considered to be excessive in the face of hemodynamic instability or when the hematocrit falls below 25 volume percent. Appropriate treatment of a woman with excessive blood loss or hemodynamic instability involves multi-component therapy, usually in fixed ratios of packed cells, fresher thawed plasma, platelets, and cryoprecipitate. The recommended initial transfusion ratio for packed red cells to fresh frozen plasma is 1:1 and is designed to mimic placement of whole blood. However, perhaps more important than the ratios, which may differ by institution, is that there is a specific protocol that is routinely followed to manage excessive hemorrhage. In the case of suspected disseminated intravascular coagulation, early administration of cryoprecipitate should be considered. Findings of critically low fibrinogen should be particularly anticipated in the case of abruption or amniotic fluid embolism, and early use of cryoprecipitate should be instituted. At Clements University Hospital, there are 2 blood orders which should be used for urgent or emergent situations when transfusion is required. The first is the OB emergency transfusion order, which includes 2 units of packed red blood cells and 2 units of FFP. Importantly, this order uses the terminology uncross-matched in relation to the blood request. However, if a valid type and screen is available, which almost all patients should have, the blood will be electronically cross-matched. Therefore, this should absolutely not deter providers from ordering or using the emergent transfusion order. These products will arrive via the tube system, and the blood bank will send them based on the EPIC order alone. The blood bank does not have to be notified directly. Very important, even if MTP is deemed immediately necessary, the emergency blood order should still be ordered simultaneously because it will arrive faster since MTP coolers take time to prepare. For the massive transfusion protocol, the first cooler will include 5 units of packed red blood cells and 2 units of FFP. Cryoprecipitate and platelets are not present in the first cooler but can be ordered in addition to MTP if needed. The blood bank must be called and directly notified when MTP is activated, and a runner must go to pick up the cooler with the patient identified. Ordering of MTP will not cancel the emergency blood orders, although the ordering can look confusing, which I'll show you in a second. At the conclusion of our first round of MTP, the packed red blood cells to plasma ratio is 1.7:1, which is much closer to recreating whole blood component therapy. And as a final take-home, just remember that if extra products are needed beyond the initial 2 units of packed red blood cells and 2 units of FFP, MTP should be activated rather than requesting individual blood products. As I already mentioned, the MTP orders can be supplemented as needed with extra cryoprecipitate, plasma, or platelets, but the protocol should nonetheless lay a standardized framework for resuscitation. When emergency blood orders have already been placed and the decision is made to proceed with MTP, a duplicate order warning may pop up. If this occurs, the ordering provider should just click Continue and disregard the warning. Do not select the Do Not Order button or the MTP orders will be canceled. This slide clarifies the situations under which each type of blood order may be used. We have already discussed both the OB emergent transfusions order as well as MTP. The third option, the adult transfusion order set, should only be used in non-urgent situations, such as in the case of a postpartum patient that has a low H&H a day or 2 following delivery. It can also be used to order blood not urgently ahead of an OR case for which there is anticipation of increased blood loss. These are newly implemented UT Southwestern practice guidelines, which are directly related to hemorrhage and transfusion. These can be found on the Obstetric Services website, which can be found on the clinical portal. This is the Clements University Hospital hemorrhage escalation protocol we've developed over the past 2 years based on feedback and lessons we've learned from provider feedback, prior cases, and simulation. I won't walk you through the entire algorithm, but I do want to emphasize the importance of communicating with all potentially relevant disciplines during a hemorrhage. This includes alerting anesthesia very early in the process, alerting the second physician in-house if emergency blood has been ordered and the patient is bleeding persistently, and finally, alerting MFM if the patient is being moved to the OR. Importantly, these providers can be alerted by nursing or other physicians, including anesthesia. All of these key players are essential to optimally managing a critical patient and need to be consistently and appropriately notified as outlined in this algorithm. That's all I have for today. Thank you for your attention.